Buenos días a todos, soy María Aránzazu López Rubio, soy su directora de servicios médicos y estoy aquí en nombre del equipo directivo de este hospital, en primer lugar para dar la bienvenida a todos y agradecer la presencia entre nosotros de la doctora Christine Seidman y del doctor Jonathan Seidman del Departamento de Genética de la Harvard Medical School. It's an honor and a pleasure to have you among us and to be able to share with you our knowledge and clinical experience. Quiero además felicitar a todos los ponentes y participantes de estas jornadas, en particular a los doctores Juan Ramón Jimeno, doctor Pablo García Pavía, doctor Eduardo Villacorta, doctor Roberto Barriales y la doctora María Ángeles Espinosa, pues gracias a iniciativas como esta y a su constante esfuerzo y dedicación y sobre todo la de todos sus equipos, que es por lo que este ciber de enfermedades cardiovasculares se considera uno de los mejores de nuestro país, ¿no? Contribuyendo en paralelo, además, estos equipos a elevar la calidad y el prestigio de los hospitales y los servicios a los que representan, situándoles a la vanguardia en el terreno de la investigación y la asistencia a la patología cardiovascular. Desde la dirección del Hospital Gregorio Marañón queremos también agradecer muy especialmente y reconocer el esfuerzo de todos los profesionales sanitarios y no sanitarios que los distintos hospitales que están participando hacen que todo esto sea posible. Y de forma muy especial felicitar a la doctora Raquel Giotti como anfitriona de este encuentro y por supuesto al doctor Fernández Avilés. Por último, deseamos a la doctora y al doctor Seidman que su estancia en nuestra ciudad sea lo más grata y provechosa posible y sobre todo les transmitimos pues, que aquí tienen su casa en Madrid y en particular en el Hospital Gregorio Marañón y que esperamos volver a recibirles en futuras ocasiones. Y sin más, pues damos paso al desarrollo de la jornada. Muchas gracias y thank you very much.
Muchas gracias. Muchas gracias, Aránzazu. Yo también quiero decir unas palabras de agradecimiento de nuevo a todos vosotros que habéis venido esta mañana, muy particularmente a la institución que siempre apoya este tipo de encuentros y todas las iniciativas que nosotros intentamos poner en marcha. Y de nuevo muchísimas gracias a los miembros de otros hospitales y a los doctores Seidman, Jonathan and Cricket for coming to Madrid and for being with us during these 2 days. So many thanks everybody. We will start immediately with the session that today will be organized in 2 talks. The first talk will be given by Jonathan and the second one by Cricket. The idea is to discuss after each of these talks with the panel, which we will constituted with the yesterday panel. It means Dr. Barriales, Dr. Juan Ramón Jimeno and Dr. María Ángeles Espinosa. So let's start with the session, and please I invite Jonathan to come to the stage.
Good morning. It's good to be to see you all again today. Yesterday's session was I learned a lot, and I'm very grateful to all the panelists. I also wanted to thank Paco and Raquel for putting this meeting together. It's been a terrific stay the last few days, and I look forward to this morning's session. So this is not a surprise to anybody in this meeting. I just wanted to remind you that obviously heart failure is a major clinical problem worldwide, and while I wish we could say that we're going to this morning talk about all sorts of causes of heart failure, we're really going to focus on one small aspect of heart failure, or one small cause of heart failure, which is idiopathic or genetic etiologies that lead to heart failure. And we've actually, in the Seidman family, we divide up the world of cardiac disease into hypertrophic and dilated cardiomyopathy. And this morning I'm going to talk a little bit about what we and others have learned about the genetics of dilated cardiomyopathy and the etiology and the mechanisms by which gene mutations, particularly in titin, lead to this disorder. So when you have a problem and you recognize that there's a disease and we need to find the gene, we've even identified some of the genes that lead to this etiology, you have to talk to a cardiologist. And over the last couple of years, these are the cardiologists that I've talked to the most, and I'm grateful for their without their insights, I wouldn't be able to make any important statements this morning. So as a geneticist, and also as physicians, you always think about the cost of your intervention. And so for geneticists, the major cost improvement in technology that's really moved this field forward has been the cost of DNA sequencing. So if you think that around the year 2004, the entire human genome was completed, and since then, at least in our institution, if we look at the cost of sequencing DNA per base, it's gone up, it's improved threefold every year, and the correlation coefficient is terrific. So I wish for many scientific mechanisms we could have an understanding that's this with such a good correlation. It's really quite remarkable, and we just hope that this cost in sequencing continues to drop at threefold per year. But right now, for €1, you too can have 100 million base pairs of DNA. To put that into perspective, the $1,000 genome is here, and by the way, when you buy gas, if you buy only 1 liter of gas, you only go 20 miles, and here we go 100 million base pairs, which is about 25 E. coli strung end to end. So there's an awful lot of DNA sequence that comes from this next generation sequencing, and it's really revolutionized the way we think about genetic etiologies and and how we can study them. And that's really important for dilated cardiomyopathy because pathologists have told us that basically all dilated, not all of them, but most of the dilated cardiomyopathies look very similar. So this is a dilated cardiomyopathy caused by a lamin mutation, but other dilated cardiomyopathies look not significantly different at the histologic level. So we need some other mechanism or some other approach for distinguishing between these different dilated cardiomyopathies. And the obvious one to geneticists, it has been to sequence. So historically we look for large families, and now with the advent of better sequencing technologies, we can actually sequence cohorts of individuals. And about 5 years ago, the field looked something like this. There were a number of genes, this is only a small subset, there were actually 80 different genes that had been implicated as causes of dilated cardiomyopathy. In some cases, the evidence that these mutations cause disease was better than others, but there were 2 genes that were of particular interest. At the time, laminase C mutations were the ones that were most commonly found, and for the clinicians, you'll remember that laminase C mutations are a little bit different from other dilated cardiomyopathy mutations because patients can be recognized because they have conduction system disease as well as cardiac dilation. Whereas for many of these other disorders, they truly have idiopathic dilated cardiomyopathy. There's no other distinguishing feature beyond the fact that they have cardiac dilation. And we were particularly interested in this gene that was way down here at the bottom. Several years ago, there were really only 2 or 3 families where you could say Titin mutations were responsible for this disorder. And one of the reasons we felt that Titin was so underrepresented is because the Titin is actually an enormous protein. So just to remind you, Titin itself is a 33,000 amino acid protein peptide, and that means it requires 100,000 base pairs of RNA or DNA to encode it. And it's the only protein, it's so big that it's the only protein that's encoded in the human genome where you can actually see the consequences of that protein in the light microscope. So if you think about when we've all seen pictures of striated muscle or cardiac muscle, and you see the striations or sarcomeres, and we know that from one sarcomere to the other, there are actually 2 Titin molecules that rest with one end in the Z disc and one in the M band. So the N terminus is in the Z disc, and the other end is in the M band. And Titin acts something as a framework or a spring to hold the whole sarcomere together. So when we recognized that this was an underrepresented, or a sequence that had not been sequenced very much, and again, because of its 100,000 base pairs, for those of you who've done Sanger sequencing, people used to divide this up into over 2,000 different PCR products and sequence those 2,000 PCR products to sequence the entire Titin Titin gene. It just wasn't done very often. So next generation sequencing changed all that, and now we routinely can ask for Titin sequence of any individual. And the first take-home message was actually quite disappointing. So if we take the Titin gene of everybody in this room, if there are 100 people here, then on average there'll be about 100 different rare variants in Titin that we've either never seen before or so rare that we can't be sure that they're not responsible for some disease, but obviously we hope nobody in this room will develop dilated cardiomyopathy. So we know that though in the vast majority of instances, these rare Titin variant, missense variants don't do very much. But what was very striking was if we restricted our analysis to what we call Titin truncating variants and other people call loss of function variants. These are variants that have a premature stop or a nonsense mutation, or they alter splicing. Those variants truncate the polypeptide, and we actually, at that time, and what I'm hoping to convince you today is we now know that those function by just making a totally inactive Titin. It doesn't get incorporated into the sarcomere, and it's either degraded or it sits in the cell doing no great harm, but on the other hand, it's not helping anything. So we started looking for these, and there was a very striking burden in individuals. So if you go to an end stage or to a heart failure clinic and just take DNA or blood from patients in heart failure clinic, up to 20% of those individuals will have a truncating mutation in Titin. By contrast, at the time, and we'll get back to this, at the time we found, and this was actually the biggest surprise, that if you look in the general population, 2 to 3%, actually in this room, there'll be 2 or 3% of the people in this room will have a what looks like a Titin truncating mutation, and yet still those people, probably not all of these individuals, will go on to get dilated cardiomyopathy. So we'll discuss in a few minutes why this number was artificially high, but what was striking is the burden. There was a 20-fold risk, and now after sequencing literally several thousand individuals, the probability that we would see this 20-fold, these 20% of individuals in end-stage heart failure with Titin truncating mutations, is the p-value is quite strong, and the increased relative risk is almost 50. But since then, we've gone on to look at other cohorts of individuals with dilated cardiomyopathy, and one of the things that's been something of a surprise, because we really don't see this in hypertrophic cardiomyopathy. We don't see in hypertrophic cardiomyopathy, if we take a cohort of hypertrophic cardiomyopathy patients, we don't see any instance where an external factor has instigated or increased the disease process. But here it's quite different. If we look at individuals who have ambulatory DCM, they're not in heart failure yet, but they're starting to have cardiac dilation. They still see this increased risk. But most importantly, if we look in a cohort of women who have peripartum dilated cardiomyopathy, there we again see the fact that 15% of these individuals have a Titin mutation. So the fact that they underwent the stresses of pregnancy seems to have brought out their mutation, and they have a much earlier onset. I should have said that in these individuals who have end-stage dilated cardiomyopathy, the average age of onset for men is about 50, and the average age of onset for women is 65. So here are women obviously in the childbearing years who have a dilated cardiomyopathy, years before they would have expected to have dilated cardiomyopathy due to their Titin truncating mutation. So we associate that with the stresses associated with pregnancy. And then more recently, our colleague and friend James Ware in London has looked at a cohort of individuals with alcoholic dilated cardiomyopathy, and again he finds that there's a significant increase of Titin truncating mutations in that population. And I wanted to just take a few minutes to remind you of yet another cohort. There's actually many of these patients were collected here in Madrid and other parts of Spain. We would like to thank all of our collaborators who helped provide samples for this study. These cohorts have been collected over a number of years. So how is this cohort defined? These are individuals who have had a cancer of almost any type. They were then treated with anthracyclines, and then several years later they developed a cardiomyopathy secondary to their anthracycline therapy for their cancer. In fact, we heard the other day that the single worst outcome associated with many of these cancers turns out to be the cardiomyopathy associated with the anthracycline treatment that they receive during the course of their the therapy for their tumor. So in this cohort, again, collectively in various centers, and we actually added 2 other cohorts. So I mentioned this cohort that was collected here in Spain and also in the United Kingdom, in the UK. And we collaborated with Bonnie Kai, who's from the University of Pennsylvania, who collected 73 patients, all of whom were breast cancer patients who received anthracycline for their breast cancer, and yet another cohort of children who had AML. And so collectively, we had about 220 patients who had been treated with anthracyclines. And quite remarkably, so we sequenced, as you do here, we sequenced basically the equivalent of your NGS panel. It was somewhat smaller, but still there were at least 9 genes on there that we have been associated by Walsh and others as being clearly associated with dilated cardiomyopathy. I told you earlier on that we think several years ago as many as 80 different genes have been implicated as being cancer causing. Now I think that number has been reduced quite significantly. So these are the set of genes that the literature accepts that are dilated. Mutations in these genes are likely to cause dilated cardiomyopathy. And far and away the biggest burden that we saw were mutations, again, these truncating mutations in titin. So a mutation that foreshortens titin here, between 5 and 10% of individuals who are treated with an anthracycline, 5 and 10% of those individuals will develop a cardiomyopathy several years post-treatment. And this is statistically much more significant. This is a very significant burden compared to what you would have expected in the general population. You can add in perhaps a few of these other genes, and I think the jury is still out as to whether mutations in other genes can also increase the risk for anthracycline-induced cardiomyopathy. I actually think that clinically, eventually people might want to think about what therapy to start using for a given anthracycline, that individuals who have, for example, titin truncating mutations, again, where it's very clear that their mutation is going to be pathogenic, that one might want to consider some other form of treatment for their tumor. These p-values are very significant. And I just wanted to point out that, so this is the list of, I don't want to bore you with a long list of mutations, but what's quite striking here is there are basically two ways or three ways that you can make a truncating mutation in titin. You can have a nonsense mutation, we're all aware of these, where you change a single codon from an amino acid to a nonsense or stop mutation, frame shift, a small deletion or insertion. But these variants here, variants that alter splicing, are the ones that we actually have the most trouble as geneticists defining. So in this study and in other studies, we initially started off by looking only at a short splicing sequence, and we'll come back to that in a moment. But in the meantime, I just want to mention that associated with titin cardiomyopathy and anthracycline-induced cardiomyopathy in these patients, actually the titin patients, and there were, as we said, 14 in this cohort of about 160 individuals, the individuals with a truncating mutation did significantly worse than the average non-patient without this genetic predisposition to cardiomyopathy. They tended to have impaired, reduced EF, they had atrial fibrillation, and they were more likely to require hospitalization for their cardiomyopathy. But otherwise, there was no significant difference. We can even model this actually in mice. There you go. Okay. So we actually have, over the years, we and others have made mouse models where we make a titin truncating mutation in a mouse. And one of the things about mouse models that I think people, the geneticists, and we're all quite aware that sometimes mouse models are better than others. The titin truncate deletion model, or haploinsufficiency model, is actually a very disappointing model. You're a postdoctoral fellow, spends probably their entire postdoctoral career making a mouse, and they make the mouse, and then you follow the mouse, and you find a mouse echocardiographer who follows these mice, and basically, if you leave them in your cage and you pay lots of per diem, the mice are just fine. They have no problems whatsoever. And it turns out that a 50% reduction in the amount of titin in a mouse is not such a bad thing. In a human, as we said, it takes 50 years to develop disease, and we couldn't wait 50 years in these mice, and they're not going to live that long anyway. So, but what is that these mice did turn out to be useful in the sense that if we take these mice and give them doxorubicin treatment, and this is actually much less than the 450 milligrams per meter squared that's used as the lifetime dose in humans, but on a per body surface area, it's used much less than that. You get the same outcome. So we treat them with doxorubicin over these first several weeks and follow their cardiac function, and you can see an impairment in both wild type and mutant animals. You see an impairment in function, but then the wild type animals improve considerably over time, and the mutant mice fail to recover. So in the absence of, or in the reduction of titin, functional titin protein, there's this recovery from the anthracycline treatment is reduced. And this actually, clinicians tell us that this is actually the same course that one sees in patients who are treated with anthracyclines. They have, over the course of their treatment, they'll show impaired cardiac function, but hopefully over time they'll recover. And again, it's those patients who have these titin truncating mutations who seem to do worse. And so this mouse model recapitulates and I think provides some insights and allows us, will provide going forward, allow us to understand at a molecular level why it is that reducing the amount of titin leads to this response to anthracyclines. So what I've told you is that there's a genetic predisposition in anthracycline-induced cardiomyopathy. There's a prevalence in particular of individuals who have titin truncating mutations. There's almost a 10 to 20-fold increase in individuals with this mutation. Mice have exactly the same phenotype. And so genetics can, and we assume that there'll be other genetic predisposing factors, but right now the strongest genetic factor that we recognize is this titin truncating mutation. So one of the things that we've learned over the last several years about titin, and this goes back to this question of why is it that in this room there are 2 or 3 people with what looks like a mutation that should alter the length of titin? Why is it that these titin variants don't cause disease? And we now know that this is related to the way titin RNA is processed into the mature molecule. So titin, as I told you, is a very long RNA, 100,000 nucleotides, and that's spliced out of a transcript that's originally 300,000 base pairs long. It's encoded in 365 exons. And here we've tried that this is an attempt to each vertical line, you can't even see them, they're so close together. Each vertical line represents a different exon. So in the A band, this is towards the carboxyl end of the polypeptide, every exon is completely spliced in. So every exon is included on this little graph. The vertical height is the PSI, or percent spliced in, and as I said, along the x-axis here is just a different exon. So all of the exons from roughly, say, 200 to 365, they're 100% spliced in. Every transcript that comes off of the titin gene is incorporated into titin RNA, and of the several thousand titin RNA molecules per cell, all of them have each of these exons. And that's true also of the exons that encode the Z line. But this region in the I band is quite different. You can see here that the percent spliced in some instances in some of these exons is really very, very low. So even though in the cell there were initially several thousand titin RNA precursor molecules that were processed to make mature RNA, in almost every one of them in this region here, they were all spliced out. And so only a very tiny fraction of the transcripts have these exons incorporated. And in these regions, obviously, there are some exons that are incorporated more and some that are incorporated less. And what we've learned is that if you have a titin truncating mutation or frame shift or a splice variant that alters one of these exons here, clearly that has no impact on disease. Those regions of the molecule would not even be incorporated into the mature polypeptide or in the mature RNA and into the mature polypeptide. So we now discount variants that we see in this region. We discount those and exclude those. By contrast, if we see a truncating mutation in this region, that's quite pathogenic. So here's an example of a cohort where 2,500 individuals were sequenced. There were 268 A-band variants. If we look in EXACT, or a large population prevalence database, we find that there are very relatively few of this, given that there were 60,000 people who were sequenced. The odds ratio, as I said, is around 50, and this p-value is quite remarkable. By contrast, if we look in the I-band, using all I-band variants, not thinking about splicing, we still see an increased risk of individuals who have disease, and those are in these exons that are highly spliced in compared to the general population. But clearly, the distribution is not nearly as skewed. There are very few, actually. It turns out that variants or stop mutations in the M band are really almost not pathogenic and barely seen in affected individuals at all. So we have a better understanding that we want to exclude splice variants that alter this region, but we also want to understand begin to start to think about why is it that these regions are spliced out and these regions are spliced in. We know that, I should mention one very interesting feature of titin is that this region of titin, where this altered splicing occurs, all of these exons are symmetric. So in many genes, so what does symmetric mean here? So symmetric means here that each exon has a number of nucleotides that's divisible by 3, so it has an even number of codons. So if we splice from, say, exon 35 to 40, leaving out 5 exons, we know that the protein will still be in frame, and this long RNA will still encode a full-length RNA molecule. or protein. That would not happen for many other polypeptides. Statistically, there are many more symmetric exons. Basically all of the exons of titin are symmetric or divisible by 3, whereas and this compared to exons across the exome is statistically remarkably significant. So titin, just over the course of human or mammalian evolution, has involved a system where each exon has exactly the right number of nucleotides so that these exons can be interdigitated without causing truncations. And why is it that in this I-band that we have this flexibility? It actually turns out it's an interesting molecular mechanism I wanted to share with you just for a moment. So it turns out that the length of titin, I mentioned to you, this is almost like a ruler or a spring that forms the distance from the Z-disc to the M-band. And this region of the I-band, which is indicated here, in titin this is encoded in domains, either an immunoglobulin domain, a PEBK domain, or a fibronectin domain. Those domains act almost as little knots on a string. And Wolfgang Linke, a collaborator from Germany, has shown that if you anchor one end of titin using atomic force microscopy, if you anchor one end of titin and then you apply a force, what happens is these little domains pop. They open up and the molecule becomes slightly longer. So each of these domains controls the length of titin, and the length of the titin is determined by the amount of strain or stress that's exerted on the cell. So you could imagine that in say, the left ventricle, where pressures are very high, you might want a somewhat more tighter or shorter ruler, whereas in, say, skeletal muscle, where muscles are not fully contracted all the time, you might imagine that you would have a much longer molecule. And that's exactly what, in retrospect, we can now measure. In fact, this same PSI type graph that I just showed you about works very well here. So and I apologize for this color scheme. This is a relatively new picture, and I failed in my color blindness test. But here you can see, this is the picture I showed you before. The A-band is very much spliced in. There's a section of the I-band that's spliced out. This is in cardiac tissue. This is spliced in. But what I show you here in blue is actually what's spliced in skeletal muscle. So with now a large number of skeletal muscle patients, these all came from GTEx. It's an online database where 450 people have had their skeletal muscle RNA studied. And you can see that the entire amino-terminal end of the I-band is fully spliced in, and these skeletal muscle proteins are significantly longer. There are not extra, roughly 50 domains or 5,000 base pairs longer, and 5,000 amino acids longer, considerably longer, and those are in these skeletal muscles where the forces are much dramatically reduced. I thought we had initially, so here you can see in black, you can see the percent spliced in that occurs in atrial tissue. So obviously atrial tissues have considerably less pressure, and it's quite striking that that the molecules are considerably longer, more relaxed in atria. And we had actually shown this several years ago, but we didn't put as much weight on it as we do now. It turns out in dilated cardiomyopathy, the percent spliced in is considerably more, and statistically this turns out to be very significant, this small difference in spliced in. There are 20 or 30% spliced in, there are 20 or 30% longer titin molecules in these patients, in patients with dilated cardiomyopathy. So the myocardium responds to the fact that the pressures are less, and they change their splicing of titin over time. So we actually can start to use this splicing assay to improve a question that geneticists have worried about for some time. So as you know, when you get a geneticist report for genetic sequencing, they will give you'll identify maybe some variants that are benign or likely benign, and then some variants that are pathogenic or likely pathogenic. But as we talked about this yesterday, the really horrible result is when you get a variant of unknown significance, and I thought it was very impressive at yesterday's session. At least 3 of the cases discussed this problem: are these variants real or not real? So yes, that's my contribution to this process. We really need to understand which of these variants that we call variants of unknown significance, which of those are pathogenic. And actually in titin, we can actually make a contribution to this field, because we need to understand better what DNA sequences are required for splicing. So just to think about, we all know that if you have a standard exon intron system, we have a donor sequence that's right here at the 5' end of the intron, and we have an acceptor sequence. This happens to be 9 base pairs and 23 base pairs. And most of us or most of the clinical diagnostic laboratories, when they call out and say this variant affects splicing, they don't look at this entire 9-base sequence, but they focus on these 2 base pairs, this GT at the donor site and an AG at the acceptor site. And based on that information, we can decide whether this is pathogenic or benign. But this ignores basically the other 9 or 7 and 21 base pairs that are in the same region. So if we see a variant that's in this donor site somewhere here, we will call that a variant of unknown significance because we don't know what it does to splicing. As you can see, although an A to G, there are exons in the world, donor sites in the world where there's 25% of them have an A and another 15 or 20% have a G, and we rarely see a C or a T, but that doesn't mean a C or a T at that position is going to abrogate splicing. So recently in collaboration, Karu Ito and Parth Patel, a talented medical student and a postdoctoral fellow in the lab, decided to develop a mini gene assay. There have been splicing assays in the world. Perhaps some people in this room have even done splicing assays. When I was 20 years ago, we used to take a piece of DNA and we would clone it out of the human genome, and then we would put it into a plasmid, and then we would put the plasmid into a cell, and we would ask that to make RNA, and then we would sequence the RNA, and we would tell you this splices or doesn't splice. So that was a very long and laborious process, and you could do that maybe on one gene. One postdoctoral fellow could do that in one lab over the course of even 6 months. But that's a very inefficient way to go through the large number of Titin variants that have been discovered to date, or Lamin or other variants. So we constructed this mini gene assay where we take a 500 base pair piece of DNA that corresponds to part of the exon and part of the intron, and put that into basically transfect that piece of DNA into a cell, and then isolate the RNA and ask what happens to RNA splicing. And with next generation sequencing, you actually get a very accurate readout. So you can put in the reference construct and it will splice remarkably well. And just to think that, for those of you who haven't used IGV, this is sort of a zoomed out version of IGV. Each of these lines represents, in general, usually represents several thousand different single reads, single DNA molecules that have been transcribed off of RNA. And you can see that essentially 100% of these reads are spliced appropriately. By making a single nucleotide change here, and we're just testing a single variant in this position, you can see now half of the reads are inappropriately or read normally, but half are read inappropriately. And this tells us that that single nucleotide change has created a change in splicing, and now we can call this, from being a benign variant, we can start to call this a likely pathogenic variant. And we've done this now for lamin and myosin binding protein C, and this is published, and we discovered on the order of 50 new variants in lamin and myosin binding protein C that were previously called likely benign, which are now clearly pathogenic. I won't show you the data for Titin, but the same thing is true for Titin. We can go back and reevaluate all of the Titin variants that have been seen, for example, in EXACT, or were found or published in ClinVar, the clinical database for showing genetic variants in Titin and other genes. And we can identify those variants that alter Titin splicing. And in this case, so we can now make calls and identify variants in individuals, and in identifying both pathogenic and non-pathogenic variants. What's particularly important about this method to us is that, whereas in the past we had to have the patient's DNA so that we could isolate the DNA fragments precisely from the patient, now since we can have these DNA fragments synthesized as G blocks, or as blocks of 500 base pairs or so, we don't need patient DNA, and we don't need control individual DNA, so that we can compare variants that are found in both controls and in cases and do a proper burden analysis. I should point out that the assay that I described, one technical feature that's quite clear is you need to have at least 500, or not at least, but around 500 base pairs per exon, donor, and acceptor. If you're much shorter than that, for the splice sites don't work very well, and the assay is impaired. So we think that this is a useful tool for characterizing variants as they come along, and if anybody, as a free advertisement, if anybody's interested in having a variant that they're worried about that might alter splicing, we can test in any gene, we can test whether it alters splicing quite rapidly, actually. So what we've said is that there are these Titin variants that are present in several different forms of dilated cardiomyopathy, and they, by haploinsufficiency, by reducing the amount of Titin, or causing tightened truncations, that they cause disease. But what's the real mechanism? So there are two, the geneticist sees a result like this and they have an immediate response. It's either that there's less titin or that these mutant titin polypeptides become incorporated into the sarcomere and they then act as a poison polypeptide and impair sarcomere function. And those two models were available in the literature for some time. We were probably the cause of at least part of that discussion. So we really want to understand how these titin variants cause disease. And you'll recall that as geneticists, this model of taking human data and then putting it in a mouse model system and then evaluating the mouse model and then perhaps making a cell-based system allows us to begin to understand and address this mechanism. Here I just told you that these mouse models, as beautiful as this picture is, these mouse models don't help us very much in understanding the mechanism by which titin truncations cause disease. But we've taken advantage of cell-based systems, and I want to take a moment to tell you about this. These cell-based systems to understand what titin deficiency does. So several years ago, Travis Inston, now a cardiology fellow in the lab, made iPS cells from patients with titin mutations and wild-type iPS cells. And then in collaboration with Anand Chopra and Chris Chen, they put these into a tug. So a tug, this actually is a small chamber that goes it's about this size, and there are two little pillars here. So you take these iPS cells in a partially differentiated state, and you mix them with mesenchymal cells, and you put them into this little tug and let them sit there for a week, and they start to grow, and it actually looks remarkably like a little piece of muscle, and these are contractile, and here you can see the contractile force that can be generated by wild-type iPS cells, and this is the contractile force that's generated by a cell containing a titin truncating mutation. And we recognized and actually one quite striking feature of these cells is that they're really not matured into mature cardiomyocytes. So actually these transcripts are not spliced in. So the full-length titin is made, a much longer, relaxed form of titin is made, and so the effect of a titin truncation is even more severe than what one would see in a normal mature adult, a normal human, or even an affected human. So the difference between the contractility of a wild-type cell and a mutant cell is really very dramatic here. But one of the things that we recognized also was that the number of titin sarcomeres was considerably less. It's a little bit hard to see in this assay, and that's what I wanted to show you next. So we've gone on and a postdoctoral fellow in the lab, Arun Sharma, has made a very nice iPS cell that we think is going to be very useful for a number of sarcomere-related projects, and I think Gregorio will tell you a little bit more about this in her talk. But what Arun did is he made a fusion where he fused GFP, a green fluorescent protein, to the amino terminus of titin. So one of the things that we want to be able to do is to ask where is the sarcomere in any given cell. This GFP marker allows us to do that. So if we look at it schematically, you can see that the GFP sits either in the Z line or in the M line. And you can see these this is just shining a laser on these iPS cells, and you can see each sarcomere stands out in the light microscope quite nicely, and so we can use this in living cells. You can see contractility, and you can actually measure the distance and the contractility of each of these sarcomeres. This can now be done computationally, so you can measure in any given cell thousands or hundreds of different sarcomeres and look at their contractility, and it gives a very precise assay. I should say that we had a lot you saw that we used tugs before, and the tugs are nice, but they're a little bit slow, and it turns out that in some instances you have to adjust the stiffness of the posts in order to be able to elicit the difference between some mutations and others. And all of that's because we would like to be able to measure, for example, as we do in adult human cardiomyocytes or in mouse cardiomyocytes, we can measure the edge. We can ask if these cells are very cuboidal, and we can look at the edge, the rate at which the edge moves across on a microscope slide. But with iPS cells, because there's even relatively well-ordered ones, the edges are not that well-defined, and you don't get a precise measure for the rate of contractility and the rate of relaxation. By contrast, if you look at the actual sarcomere, you can measure very accurately, and again, hundreds of them. So you can measure quite clearly the rate of contraction and the rate of relaxation. So if you, here's just an example of where if you pace them, you can show that, of course, the rate of contraction is increased. You can do this with pharmacologically. I'm not going to show you all of those. I'll just show you some pictures. So here's an iPS cell, a wild-type iPS cell, and you can see the contraction. And so computationally, you can calculate the rate at which these sarcomeres are coming together and coming apart. What was quite striking is when you look at a cell which is a tight and truncating variant, obviously here, I think it shows up much more clearly, there's much less mature sarcomere. There was a question as to whether these few sarcomeres that are made, are they normal or are they abnormal? Do they have normal contractility? And quite clearly when you measure the contractility, I hope you can see in the back that this cell is also beating. But because there's so many fewer sarcomeres, it's hard to tell that they're actually beating. But the rate of contraction and the rate of relaxation are precisely the same as the wild type. So the sarcomeres are normal, there just aren't as many of them. And we think that that's a mechanism by which these cells are failing to proceed. We've learned another an interesting feature about how sarcomeres are made from these cells and cells like these. This again was done in collaboration with Anant and Chris Chen. So if you take a cell and you disrupt its sarcomere and then you ask what happens when you put the sarcomere back together, these are 4 different pictures taken from over the course of about 24 hours where you can watch sarcomeres reform. I'll show you that as a movie. So here, this cell, they lay down their first sarcomeres. The sarcomeres actually start at the edges and then grow in towards the middle. In this case, the cell is very disorganized, but the nice thing, as I told you, is that since you can see where each sarcomere is, you can measure sarcomere function. But it's quite striking that the sarcomeres grow in towards the middle from the periphery. And we think that that's probably an important question. And if you have reduced numbers of titin, reduced amounts of titin, then the question is, how does this affect sarcomere function? One of the useful features of the system that Chris and Anant have put together is that you actually, these cells are grown on what are called micropillars. The layer of the surface contains many small little pillars that stick up, and you can actually measure the force and the tension that's generated as these sarcomeres or these cells are being recapitulated, and that's diagrammed here in these wild-type cells. And it appears that each of these sarcomeres starts at a protocostomere that's at the periphery of the cell, and then, as I told you, the sarcomeres are generated in towards the middle. By contrast, if we look at a cell that has much less titin, you can see basically the same events start to occur out here in the periphery, but presumably because there's much less titin, and I think this is a question that still needs to be resolved, is that there's less tension here, and so they don't form and are able to start joining sarcomeres forming in towards the middle, or is that there's just less titin, and that means that there's less tension. I think that's an interesting question, but the short answer is that if you have less titin, you have less sarcomeres, and I think that's the mechanism by which this leads to a dilated cardiomyopathy. So what we've learned is that we can use these IPS titin GFP lines to study sarcomerogenesis and also the mechanism of titin mutation. Eventually, I think that we're going to be able to address, for example, the many titin missense mutations that I told you that we all have. Are any of these pathogenic? We can study them in this type of cell because we just ask whether a missense mutation, which we can engineer into this cell, whether it reduces the amount of titin and reduces the amount of sarcomere. And we think we learned a little bit about the mechanism by which, so haploinsufficiency in humans has told us that we need protocostomeres and titin interaction with the protocostomere to form a new sarcomere. If we have titin insufficiency, we just get less sarcomeres. And so this leads to an inadequate response to a variety of mechanical stimuli, and explains why we see an increased number of mutations in individuals who have peripartum cardiomyopathy, alcoholic cardiomyopathy, or anthracycline-induced cardiomyopathy. And with that, I think I'll stop. Yesterday, at the end of each presentation, it was very nice. There was a series of questions as to why, what's the answer to this case? So my question is, why is this relevant to the next talk? So your job is to figure out what that small tarantula has to do with cardiomyopathy. Thank you.
Thanks, Jonathan. Wonderful talk. We will ask the members of the panel to go to the stage. Also, and Dr. Jyoti. And let's start with the questions and comments from the audience.
Thank you.
Salamanca.
Amazing information. Now, probably a very stupid couple of questions which are related. We've been reading and studying Titan mostly in the field of HPEF, average ejection fraction. So first question, given this is a spring where the most mechanical effect one would understand in a pure mechanical basis is impairing elastic recoil, why doesn't Titan mutations induce an HPEF phenotype? Instead, I understand what you explained, but maybe some subtle forms, wouldn't you expect preserved ejection fraction phenotype? And second, why don't inherited cardiac diseases induce in this particular phenotype? We go into DCM, but not into HPEF.
Yep.
So
I think that, let me just make sure I have the question correct. But you're saying, why is it, if we think that Titan functions like a spring, why is it that we don't see basically impaired relaxation? And I would say even broader, if we understand the mechanism by which Titan truncating mutations cause dilated cardiomyopathy, does it tell us anything about HFpEF or other forms of cardiomyopathy? And so I think the hypothesis is a fair one, except for the fact that what these mutations are actually doing is just reducing the amount of sarcomere, period. So that's why it was so critical to know how many sarcomeres there were. So the alternative mechanism would have been that there were an equal number of sarcomeres that were present in these cells, and each of them had impaired function. But that's exactly not what we see. We see rather that there's just fewer sarcomeres. Those sarcomeres that are present have the same amount of contractile force, but there's just not enough of them. And in fact, when you think about therapeutic approaches, it would be marvelous, at least for Titan cardiomyopathy, to just increase the amount of Titan. And it wouldn't matter whether it was short or long particularly, we just need more of it. So I think we can explain a little bit why we don't see this spring problem just doesn't arise here. But it may be that some missense mutations do that, but obviously having the appropriate missense mutation that would make that you're asking much more of the mutational mechanism, so you're creating a new poison polypeptide activity rather than here we're just truncating the protein, and we know there are lots of ways to make a truncated polypeptide.
Thank you. Eduardo, friends from Salamanca, are you there?
Yes, we have two questions from the audience here in Salamanca. The first one is if, according to the results that you present with the dilated cardiomyopathy secondary to the cardiotoxicity, would you recommend to make a genetic test to all these patients who develop this cardiomyopathy? And the second is in this line. I would like to know about the genetic counseling to this patient and the family. Do you have any information about the penetrance in the family in these variants? What will you recommend to these patients? Will you change the oncology treatment to these patients? I mean, if they have a cancer that the best choice to treat is anthracycline, would you recommend to stop that treatment and to start another treatment? Thank you.
Thank you for that. I must confess I had a hard time hearing the second question. The first question, if I understood it correctly, was does one think you could generate a genetic test for patients who are particularly at risk for cardiomyopathy secondary to anthracycline treatment? And so should patients who are going to undergo anthracycline therapy, should they undergo this genetic test? So as a geneticist, as I said yesterday, whenever you ask me, should I do a genetic test, the answer is yes. And in this case, in particular, yes. And so I think even here, there's even real merit to that. We're saying that roughly 5 to 10% of patients who are going to who will develop dilated cardiomyopathy secondary to their anthracycline treatment have a Titan truncating mutation. It's actually relatively low cost to know whether they have a titin truncating mutation. And again, you can know just looking at their DNA sequence, you can say with high probability, yes, this is truncating or not. So you can make the assay is very sensitive, and the cost is really not that high, all things considered, when you consider the cost of managing somebody's heart failure. I think the bigger issue is that in the various oncologic fields, they have to decide whether there's an alternate treatment. So if there's no alternate treatment to anthracycline, then maybe the test isn't so useful. But otherwise, if there is an alternate treatment, then clearly having a genetic test would be very helpful. The second question, maybe I'll try and restate what I think you said. I'm sorry, there was an echo. I just didn't quite get it. But I thought you asked what's the penetrance of these titin truncating variants broadly, and in any given family, what's the penetrance? Is that the question? Did I get that right?
Yes.
Yeah, that's the part of the question, the penetrance, and the second is the genetic counseling to the patient and the family. If you will change the treatment, the oncology treatment to this patient or to a familiar member.
Okay, so I'll start with the penetrance question. So a number of years ago, we looked at cricket, or went back and re-studied a large. So some people call this Mendelian randomization. So the highest frequency of titin truncating mutations in the entire world are in family members who are at 50% risk of inheriting the same titin truncating mutation. And you can ask whether those 50% of patients, those who inherited the variant, are they at risk for cardiac dilation? If you go back and look in appropriate age families where the siblings are, let's say, in their 40s to 60s, the penetrance is remarkably high in that the prior probability is they'll have some form of cardiac dilation, and they will, in 95% or more of them, will have some dilation. They may not reach clinical standards. Their ejection fraction may not fall below 30, but they have clearly reduced ejection fraction. So the penetrance is remarkably high. The age of onset varies quite considerably, though. So as I said, for men, the average age of onset is about 50, and for women, the average age of onset is about 65. So if lifetime, the penetrance is very high. Obviously, if you look in younger family members, you may see much less evidence of disease. But those individuals will, at least following historical precedent, those individuals have a very high probability of going on to develop some form of heart failure. And I think if I understood your second question correctly, can one change cancer treatments based on genotype? So that's a question that I'll leave to the oncologist. I would hope so, but that's not something that don't ask me that question, or I can't really. Maybe somebody on the panel wants to take a pass.
Okay, more questions or comments from the audience, from the panel?
Congratulations for a wonderful talk. I would like to ask you, in your opinion, what would be the most important things that could affect in peripartum state with this particular role of titin truncating mutations?
Yeah. So just to restate, so is there anything that one can offer a mother who has peripartum cardiomyopathy due to titin truncation that might be different from an individual with a different titin cardiomyopathy? I think nothing good. So if they have it's very similar to the mouse treatment with anthracycline. Once you put the stress on these titin hearts, they need to regenerate more sarcomeres. And the titin truncating mutations seem not to regenerate well. So right now, we just don't have anything that encourages sort of sarcomere.
I think it's
Or is
a
that
more
not the question?
practical clinical question. So we do know that if you unload a titin heart, that they respond better than does a heart that doesn't have this decreased capacity to mount increased tension and pressure in response to load. So there have been a number of studies now that show if you after load reduce them, these patients do better, and that can be with pharmacologic agents and in fact with LVADs. There's a number of clinical studies that show those who respond to having an LVAD placed and then they suddenly get impressively better, a lot of those individuals turn out to have a titin truncating variant as the cause of their DCM. And whether that's relevant to peripartum cardiomyopathy, it's too rare a disease to know in the aggregate, but I would think that it would be the same. I think what it says is that if the heart can recover and you give it time by after load reduction, there's an opportunity for the sarcomeres to regrow. That's the mechanism we're all working on right now, but clinically after load reduction, mechanical or otherwise, is really beneficial in this population. And that's different from a lamin AC mutation where we don't see that kind of recovery at all. So I think it really does make a difference.
So I learned something in Madrid, thank you. I just want to say the nice thing to me is that we now have an assay that might explain, if Cricket's hypothesis is correct, you could look, I mean, assuming the biopsy tissue was available, you could actually ask whether the amount of sarcomeres was increased or not before. I mean, in your dreams, you would measure sarcomere content before and after altering afterload and ask whether sarcomere formation occurred during that process.
More comments, questions?
First. Okay. Okay. So thank you very much for the impressive talk. I also have a very practical question. Sometimes we see in clinic families, or maybe not families, just patients that develop DCM with a very particular trigger, as you said, for example, alcohol, AF, and even sometimes these kind of patients recover ejection fraction over the time. And when we see in the same family different relatives that develop DCM with different triggers, even if the patients recover ejection fraction, do you think that maybe there is a common genetic background, and do you think we should test these families? Because in common clinical practice, at least here, sometimes we don't think in testing these families. So what do you think?
So maybe I'll defer to my clinical colleagues, but personally, again, you're asking the question, should I do a genetic test? So the answer is yes. But beyond that, clearly, as you are implying, it's not common that we would expect, say, in the same family to see someone with alcohol-induced cardiomyopathy and peripartum cardiomyopathy perhaps in the same family. The incidence of peripartum cardiomyopathy is not all that high. The incidence of alcohol-induced cardiomyopathy is low as well. So to me, yes, I would say that there's a real possibility, and one really should test for that. Again, the nice thing about it, there should be very few VUS variants of unknown significance in Titan, for example. It is true that there's these other 9 or 10 genes. Their missense variants seem to play a greater role in causing disease. It's not so clear that just haploinsufficiency causes disease. So you'll miss those. But Titan is one where you really can have an opportunity. So some fraction of families will be positive.
Thank you.
Thank you very much for the presentation. I would like to ask about 18 to 20 variants and prognosis. Is there any difference, or do you know any difference in terms of gender? I mean...
Yeah. So definitely there's a gender bias. And so in all heart failure broadly, as you know much better than I, in heart failure broadly, there are more males in heart failure clinic than women. It's almost 2 to 1, I think, something 60, 30, 60, 40. So there are many more men. And here, the age of onset for men, just like other forms of heart failure, the age of onset is much earlier. So men 50 years old will start, half of them with these mutations will have some sign of heart failure, whereas women wait 15 years longer, which actually statistically that's dramatically longer. And when you go back to these families and you ask what's the age of onset, there's this very clear shift. One of the questions that sort of people coming into this field today are supposed to answer for us, why is it that men develop heart failure much more rapidly, much more earlier in life than women? And related to that question, why is it that Titan mutations have that I had thought that if any sort of etiology of disease was going to not show the same gender bias, it would be something like a Titan mutation compared to, say, diabetes or other mechanisms that lead eventually to heart failure. But that's not the case. So it's something about the male heart versus the female heart that predisposes it to developing heart failure or reduced ejection fraction much earlier. And we don't know why, but it's very clearly true.
Eduardo Zatarain.
I have 2 short questions and 1 brief comment. The first, have you seen any relation to the sports in T10 variants? The second one is, do you have any relation or correlation between the number of missense variants in T10 and if it makes any change in the protein because genetic noise? And the comment is about the cardiotoxicity. I think right now the real balance between the risk, the benefit of giving or not anthracycline to some genetic susceptibility patient is not well measured. First, because the real incidence of cardiotoxicity with the new regimens, doses, and prophylactic treatments are not well known, and also because simple things like risk factors control and probably changing some treatments, for example, giving AC inhibitors instead of other antihypertensive drugs could change the prognosis. And I think it's too early to say that we would not give anthracyclines to somebody because it has a truncated titin right now.
So sports. Yes, sports. Sorry. Thank you very much. I got it when it's a one-word question, then I could get it. So I should again defer to Greg. Maybe you have some thoughts, but I don't believe there's any clear. There's no evidence, for example, of sudden death or athletic stress dramatically increasing the amount of dilated cardiomyopathy secondary to these mutations that I know. That no. I've consulted with my clinical colleague, and she says no.
I would agree with. I don't think anybody is suggesting you change cancer therapy based on titin truncations. I mean, I wouldn't want anyone to think that. I think that it is a recognition that when one's thinking of therapies, and we've found these mutations not only with response to anthracycline, but testrucimide as well. And so there are a number of noxious agents that we give to cancers. We all recognize that. And sadly, the outcome is often something cardiovascular. Being able to repair that heart is going to be really important. And there's some evidence that additional protective agents, either lowering the doses, protracting the therapy longer, and not coupling it with radiation and combination therapy, it might be that kind of an approach that may be more beneficial. A diagnosis in this instance isn't a therapy. It's just a recognition that this person's at higher risk. And that's the best we can say right now.
I agree with Greg. I didn't mean to say that you should change dramatically therapy, but there are clearly choices that are made. For example, what's the lifetime dose that you want to give to a person who has any tumor? There are clearly ranges. It's not an absolute number, and for a person with one of these variants, one might think about using a lower dose initially, at least, rather than use the full dose. And there was a third.
The amount of missense variants in T10.
So this is a real problem we geneticists have with rare variants, is that they're very prevalent in the general population. As I said, 1 per titin. So detecting a burden is really hard. So let's just say that 1% of these rare variants are going to cause disease. Determining which of those 1% is informatically is right now it's not possible. I mean, you can make as many meta-SVM scores as you want. It's really not possible, especially in a molecule like titin, where we don't even really know the three-dimensional structure. We have some idea of the three-dimensional structure of some of the domains, but overall we don't know what the real three-dimensional structure looks like, and we don't know what these missense variants would do to structure, and we don't even know intimately. So, for example, if a missense variant were to affect myosin binding, how would that affect sarcomere function? So there's a lot of chemistry that needs to be worked out. I think one of the nice things about these green iPS cells is that we really can start to distinguish that pretty soon. If we constructing missense variants and iPS cells is it's 2 weeks from the day you put the construct onto the cell to the day you start to have clones, and it's another 2 or 3 weeks till you start to have clones that you can actually start to study. So a month to study each variant, and then if you can look at them histologically, you may really be able to understand whether those proteins become incorporated into the sarcomere and whether contractility is impaired. So I think one's going to be able to start to ask those questions. It just hasn't really begun yet.
Okay. Welcome to the meeting, Pedro. More questions from Salamanca or comments?
No, I don't think so. I think it was perfect, the discussion, so congratulations.
Adolfo.
Jonathan, I have a question here.
Oh, sorry.
I have a question. I don't know if it's a question or a hypothesis. You told us that some mutations, titin mutations, cause impaired ability of the cells to create new sarcomeres. So I've been thinking about stem cell therapy with autologous iPS cells, and would this cause a failure of the therapy if the autologous cells has the same mutation, in case the treated patients has a dilated cardiomyopathy caused by this?
Yeah, I don't think
mutation?
I agree with. So the question is, do autologous cells seem useful for patients with titin cardiomyopathy? I agree with you. They would probably not be the first cardiomyopathy on my list. I'd want to stay away from those, just because each myocyte that you put back in is not as good as a wild type myocyte, unless you had some way. Certainly, one thing to think about is, because it's just a reduction in the amount of titin. If we knew how to boost up the amount of titin of the normal allele, that could be therapeutic. So if at the time that you're making your autologous graft, you're figuring out how to turn on the wild type allele, then there's real hope there. But I agree with you, putting in myocytes that have half the normal amount of sarcomere, those would be the least likely to be productive of all the cells that you could put back.
So I know the answer, but would you recommend a genetic test before enrolling a patient in an autologous iPS cell stem cell therapy trial?
I think it's a fair question, but I would hope that by the time a patient had surgery and had gone through this whole process, that they had had a genetic test already. So hopefully you knew the answer to this question before you get there.
So many thanks, Jonathan. Let's move to the next talk, which will be given by Christine Setman.
I have to begin by thanking Paco and Raquel for having us and for having such a lovely couple of days here in Madrid. It's the first time that John and I have ever been to Madrid, and his first time in Spain. And we must admit that this is a beautiful city, and more importantly and relevant to the kinds of work we get to do is we've very much enjoyed the collaborations over the years and hope that young people who want to see a snow-laden city might think about coming to Boston for their future training and postdoctoral careers. I'm going to talk to you today about hypertrophic cardiomyopathy, as John alluded to, and Paco had sent me this title, Genes and Heart Failure from the Molecule to the Symptom, and I want to address that, but I think I'm going to do it in a little more humorous beginning, at least, because I'm really going to tell you about hearts, spiders, and relaxation. So, as we heard yesterday, many of us became interested in inherited heart diseases because of our clinical patients, and that's been very much true in my personal history as well. And so I thought I'd begin with a story of an individual who was cared for at the end of his life at the Brigham and Women's Hospital where I practice. And this, as you can see, is a 30-year-old man. He's going to have his gallbladder removed. There's nothing really exciting going on. He was seen in an outside hospital, and a murmur was detected, but other than that, there wasn't anything particularly exciting. No one had obtained a family history, which is very often the case in our community hospitals in the United States, but that murmur, and because he was going to have surgery, prompted routine bloods, chest x-ray, and of course an EKG. And this is his EKG. I hope that all of the fellows in the back of the room will recognize this is not within normal limits. And in fact, because of the voltage and the flip T waves across his anterior precordium, the anesthesiologist asked for a cardiac consultation, who did troponin T levels and decided first off that he wanted to do stress nuclear imaging. I can't imagine why, but ultimately he settled on doing a two-dimensional echocardiogram. And here you can see the cause of his murmur. We like to say that even a geneticist can see there's something the matter with that septal wall. This individual was diagnosed by the consultant in the patient in the community as having hypertrophic cardiomyopathy. Because of that, they recommended that he could go forward with his surgery, and they recommended a laparoscopic cholecystectomy. This probably would have been appropriate under some scenarios had this been a well-controlled and carefully managed patient where a lot of information was known about him before his surgery, but unfortunately he went on that very afternoon to have his surgery and had an intraoperative course that was absolutely devastating. This is a small tracing. I hope you can see it again for the fellows in the back of the room. The rhythm is AFib, yes, okay, very, very common in hypertrophic cardiomyopathy. It occurs in 25% of individuals. But in his instance, it was associated with profound and sudden onset of respiratory compromise. He became hemodynamically unstable. They were unable to maintain a pressure, and the anesthesiologist called for a cessation of the surgery and to begin other investigations. There was concern about acute heart failure and for emboli. They went on to do a transesophageal echocardiogram where they found profound LV dysfunction. Clot was recognized in his left atria. And they did a pulmonary angiogram which showed multiple emboli throughout his pulmonary tree, and they placed an inferior vena cava filter. At that point, when he was semi-stabilized, he was transferred by ambulance to the Brigham and Women's Hospital, where he was in the emergency room for about 15 hours with marked heroic efforts trying to maintain pressures and restore some semblance of hemodynamic status, and he died within 15 hours of arrival at our institution. This is his heart at postmortem examination, and I think it's pretty clear why he had such a horrific response to his arrhythmia. He probably had had left atrial as well as right atrial thrombi for a number of years. He probably had had intermittent AFib in the past, but what you can see is that these clots that were present in the atria actually had disseminated throughout his systemic vascular bed. The pathologist suggested that he died from heart failure, which was true from a clinical perspective, with fulminant circulatory collapse, largely precipitated by peripheral thrombi that were disseminated throughout the vascular bed. So he, of course, had profound left ventricular hypertrophy, and with that had a history of atrial and ventricular tachyarrhythmias. But you'll notice that the pathologist did not call this hypertrophic cardiomyopathy. Rather, they made an anatomical diagnosis that described the cause of death and left the confluence into a clinical diagnosis for someone else. And I find that interesting and important because we know that while we see what looks and feels and smells like hypertrophic cardiomyopathy, that there are many other genetic causes that could give at least a similar picture. So when you go back in terms of the literature on hypertrophic cardiomyopathy and you ask, what is this disorder? We clinicians have made incredible numbers of wonderful case history reports, and they describe many of the features that have been labeled with a variety of different clinical terms, often of which we call hypertrophic cardiomyopathy. My favorite one is stenosis of the ejection chamber of the left ventricle.
I think that means there's another chamber in the LV that I don't yet know about. That preposition's a bit off. But be that as it may, many of the critical descriptors when I was first beginning to think about this disease were characterized by the word idiopathic, we didn't know what it was, and familial. And those two combinations are what really led people to surmise that this was likely to be a genetic disease. And so as John told you, over the past several decades, we have looked at families and tried to understand first a locus, a region of the chromosome where a disease gene was residing, and subsequently what was that disease gene. And in the context of hypertrophy, there have really been three major classes of genes that we can group along different potential mechanisms by which they change cardiac biology. There are those that alter the heart morphology because they tend to fail to clear normal cellular debris or abnormal debris. So for example, when you have misfolded proteins due to a desmin mutation, they tend to clog up the recycling machinery in the heart and they become deposited within the cell. Similarly, if you have a mutation in lysosome-associated protein number 2, normal processes of autophagy are disrupted and you acquire in the sarcomere and throughout the myocyte these large autophagic vesicles that are not appropriately processed. These accumulations over time lead to death of those cells, and so these cells and these mutations are often associated with a huge amount of fibrosis, in large part, I think, due to myocyte death. There are a number of other gene mutations that actually perturb a portion of intermediary metabolism of the cardiomyocyte. One of the ones we've been looking at for a number of years now is PRKG2. This is a mutation in AMP kinase, and it is an activating mutation. It increases the input of glycogen and glucose within the cell and shifts the whole metabolism of the heart to use more glucose than fatty acid, as it usually does in beta oxidation. And all of these different disorders are in some ways altering cardiac metabolism, and they can result in a moth-eaten appearance of the myocyte unless you take appropriate preservations of the tissues to prevent the washout of the glycogen. Interestingly, these metabolic disorders that result in glycogen accumulation also always poison the conduction system. And so these are the hypertrophies in which you often see progressive AV nodal dysfunction and the emergence of AV block. Then, of course, there are the hypertrophic mutations in which we think of the mutations being largely in genes of the contractile apparatus and ancillary proteins in the sarcomere. So you've heard a lot about a paper yesterday and a bit today from Roddy Walsh and colleagues at Oxford. And what they did is they asked of all these different hypertrophic genes, which ones are the most common and which are the ones that we should be particularly attentive to. So to do that, they sequenced 6,000 individuals who were clinically diagnosed with HCM, not LVH as I would prefer to call it, and they compared what they found in those 6,000 patients to the prevalence of variants in about 60,000 controls. And what you can see here is they characterize the variants as being definitively pathogenic, they're Mendelian, they're transmitted in a familial fashion, and we've seen it over and over again, likely pathogenic where there's less certain but still actionable evidence that this is disease-causing, the dreaded VUS, and then again normal controls. And what you find is that the pathogenic and the likely pathogenic are particularly rare. They're usually damaging, they're loss of function or deleterious missense mutations. They're very often found in the familial dominant transmissions of these diseases, and they appear to be enriched in some genes. In particular, in the diagnosis of clinical hypertrophic cardiomyopathy, two genes, myosin-binding protein C and myosin heavy chain, myosin 7 that is, and then a smattering of other genes which collectively all account for about 2% of cases. But what's equally important is in 60% of cases, they did not find something they could call pathogenic or likely pathogenic. So there's a lot to do in this field, and I want to acknowledge the contributions of all of you guys in green in the back who will make these discoveries in the future. And I'm going to tell you who's going to tell you how to lead the way. And she's sitting in the front row, and that's Raquel Yotti. So Raquel came to us and spent about 6 months in the laboratory to really focus on those individuals who were panel negative, in whom they had sequenced lots and lots of these hypertrophic genes, and no definitive mutation was identified by the panel sequencing. And when you do that, sometimes you find these panels miss mutations that are in well-described genes. That's not a surprise, because even though the panels can be very, very high coverage of a particular gene, sometimes the uniformity is more important. And so she found in about 30 of those 200 cases that there was a mutation that had escaped detection. But then if you go on further, you'll see that 189 were truly negative, and those went on to have whole exome analyses. And I want to tell you just very briefly a little bit about what Raquel discovered. And what she found is really 3, I think, important points. The first is that some of those variants, as I mentioned before, had escaped detection by panel analyses. And as well, they escaped detection either because they were not sequenced, and in this instance, there was an intronic variant within myosin-binding protein C, a definitive hypertrophic mutation. And as John mentioned a minute ago, we now have evidence that we can see some of these VUSs are actually splice altering, and this one actually creates an inappropriate splice site in the middle of an intron, causes downstream abnormal sequences, and it so is a loss of function mutation in C protein. Another thing that she discovered is that there are rare variants in many of the genes that the Walsh paper recognized, but they don't see a burden in the general population of the hypertrophic population. One we heard about yesterday, this is in the actinin gene, and we know that while these are not ever going to make statistically important contributions across the worldwide prevalence of hypertrophic cardiomyopathy, that in these particular families, they really are important to recognize and to see them as pathogenic. And then she's also found a number of very interesting variants that are not individually significant, but we keep seeing that damaging variant across all populations of patients with either another hypertrophic mutation or no known cause for their hypertrophic mutation. Whether these are going to turn out to be modifiers or in fact are contributing to an oligogenic cause of hypertrophic cardiomyopathy remains to be seen. But I think that these 3 categories, missed variants, variants in genes that we recognize but they're a rare, rare cause, and again, multigenic causes are going to account for that 60% of missing disease mutations in HCM. So if there are lots more to discover, and we know so many already, does it matter? And I would like to convince you that it really, really does matter in terms of patient care. My colleague Carolyn Ho has spearheaded with lots of people in the United States and around the world now the collection of patients with hypertrophic cardiomyopathy, and they're going to now reach out to dilated cardiomyopathy, and they've combined in a de-identified way to protect patient confidentiality approximately 4,500 individuals with this condition, and together that amasses 29,000 patient years. That allows you to begin to dissect whether genotype matters in terms of clinical outcome. And I won't tell you all of the data, but just to give you the highlight. If you take those group of individuals in those 2,500 who have a sarcomere mutation, pathogenic or likely pathogenic, and you compare their incidence of heart failure, ventricular and atrial arrhythmias as compared to those who do not have a sarcomere variant, you can see that there is a striking difference in terms of the natural history, if you will, of each of those. Moreover, if you look at patients who have the dreaded VUS, they sit halfway between the two. Now, I don't really believe that there are some mutations that are half as bad as a sarcomere mutation and better than no mutation. Probably what that means is that VUS is a combination of both people who are misannotated as having a pathogenic a VUS when they in fact have a pathogenic, and others who truly have a benign. So figuring out those VUSs may separate these two curves into only two, and we think that's really worth the effort, given that just knowing a definitive mutation should tell you that's a higher risk patient than someone who does not have a mutation. Okay, so if it matters, what do we do when we are faced to deal with a family who has lost a person who was going to have an electric cholecystectomy? Well, needless to say, we did do genotyping in this individual, and in fact, a mutation in myosin heavy chain was found. Okay, so we've confirmed the clinical diagnosis. Is that enough to do? Well, I would suggest no, because as I just tried to tell you, we should have been able, if we'd known that in advance, to at least recognize the likelihood that he could have had greater risk in an intraoperative scenario, and certainly more broadly to intervene, especially for individuals from high-risk families with sudden death events. But in addition, when you know that, you clearly can identify individuals at risk. And this is a pedigree not different from his, and what you can see is his diagnosis and death here led to the recognition that several other of his family members, and indeed his mother, all had exactly the same mutation. But importantly, if you look at the next generation, there were children who carried the mutation, but who did not yet have any evidence of hypertrophic remodeling. And I would suggest to you that knowing that is good. We could potentially follow those children longitudinally, watch them carefully, prevent them from participating in sports, but that's not a really good way to take care of a disease, to watch it emerge simply by observing patients. And so for a long time, we've thought that we needed to understand what do these mutations do to sarcomere functions. And again, I want to come back to the two most major genes, C protein and myosin heavy chain, because those account for more than 50% of all genotype positive patients with a clinical diagnosis of HCM. Now, first off the bat, these are somewhat complicated to think about because all myosin missense mutations, are missense. They substitute one amino acid for another. The vast majority of C protein mutations are truncating. They reduce the content of myosin-binding protein C by about 50%, just like Titin. So we already have a little dilemma that the same clinical phenotype can result from a subtle change in a contractile protein or 50% reduction of a contractile protein. How does that happen? Well, from a myosin point of view, we've known a whole lot about what the motor protein of the sarcomere really does. From very elegant studies by David Warsaw at the University of Vermont, Jim Sputich in California, they have developed ways to actually measure the force of contraction of a single molecule of myosin by producing a thin filament of actin and watching as the myosin heads push that thin filament, and they can measure the force by atomic microscopy. So it turns out when you do that and now use a myosin that carries one of these HCM mutations, you find that the sliding velocity of actin is increased, the force is increased, and the ATP hydrolysis is increased, all of which suggests, in fact, that these are increasing sarcomere power. They can increase it by increasing the sliding velocity, or they can increase it by increasing the force of contraction, but the net result is an increase in sarcomere power. These are activating mutations. Well, that was sort of interesting, because as it turns out clinically, when we see echocardiograms from patients with these mutations, one of the earliest manifestations is hypercontractility. Indeed, if you look at these individuals who are genotype positive at the bottom here, and they don't yet have hypertrophy, and you look at their force of contraction, it is already accelerated in comparison to their siblings who don't carry the mutation. Moreover, Hugh Watkins and colleagues has shown that in addition, you have increased ATP consumption even before there's hypertrophic remodeling. So that says that it is not a consequence of the remodeling, but rather it is a very proximal consequence of these mutations. I like that result because it basically also may suggest a mechanism for the increased fibrosis that occurs in hypertrophic hearts. We've known for a long time now, if you were to take cardiomyocytes, mix them with fibroblasts, and then stretch them on a elastic membrane, that you can generate power and force, and that is transmitted from the myocyte to the non-myocytes. When you actively stretch non-myocytes, they increase TGF-beta expression, and that will activate the expression of lots of pro-fibrotic molecules, which are extruded into the cytosol and the surrounding area and can swallow up the myocytes. I like that because it seemed to explain that increased mechanical pressure from power from a mutant sarcomere could increase the amount of interstitial fibrosis. Okay, there's actually a trial that Carolyn Ho is spearheading right now to try and abrogate that signaling pathway by using, in an indirect way, a means of decreasing TGF-beta expression by using the sartan drugs. But do hypertrophic mutations cause disease only by increasing sarcomere power? Well, I told you before that there's another gene, the C protein mutations, that clearly are a loss of function. That doesn't seem to make sense in terms of increasing power if you lose the function of a power component of the sarcomere. Moreover, the myosin mutations are not clustered in any domain that is specific for hydrolyzing ATP or interacting with actin. Rather, they're dispersed throughout the entire head of the myosin molecule. Finally, most protein mutations in any human disease generally decrease function. Rarely do we think about disease arising from too much function. It happens, but it's not very common. And I think most importantly is that increased sarcomere power really doesn't explain symptoms, something that Paco told me I must address today. Okay, so why do you get symptoms in HCM? Well, the clinicians all know the answer is diastolic dysfunction. When you have impaired left ventricular relaxation, you can have increase in the passive stretch of the atria because of reflective pressure into the left atria, because in fact atrial filling, as we all know, occurs when the ventricle is relaxed, and if there's increased pressure, you'll stretch that thin wall chamber, and that over time can result in a propensity for arrhythmias and to lead to thrombosis, as we've shown in my patients. In addition, that increase in pressure can be reflected back into the pulmonary beds, and that obviously will result in shortness of breath in response in particular to exercise and other conditions. And finally, when you increase ventricular filling pressure in the relaxation phase of the cardiac cycle, you are going to impair coronary flow to the inner myocardium. And that ultimately can lead to endocardial ischemia that we often see in lots of hypertrophic hearts on postmortem examination. Moreover, just as we saw in patients who were genotype positive but without hypertrophy yet, how they had increased ATP consumption and increased ejection fractions, we know now that their relaxation capacity is perturbed before they have hypertrophic remodeling. So these are Doppler tissue imaging from a normal individual in a preclinical person who carries a mutation, and already their E' velocity is about half normal. So this turns the question from how do hypertrophic mutations cause disease by too much sarcomere power into how do sarcomere mutations cause diastolic dysfunction. This has been a really changing landscape of science in the past couple of months. And I want to tell you a little about it because I think it's very important for oral cardiologists to be aware of this. We have focused most of our emphasis in studying cardiac biology on the contraction of the heart. And I want to convince you that relaxation is indeed as important, if not more important. So some very recent studies from biophysical analyses have shown that during relaxation of any kind of striated muscle, that myosin heads tend to form conformational changes that are dependent on pairs interacting in particular motions. And what they do is undergo two distinct and very dynamic conformations, and each of those conformations is associated with a different rate of ATP consumption. Moreover, we have names for these. They're called disordered relaxation and super relaxation. In disordered relaxation, there's 6-fold greater ATP hydrolysis than in super relaxation, and that's because in these paired interactions with the disordered state, one ATPase is sterically inhibited by the conformation, whereas in the super relaxed state, both of the paired ATPases are inhibited. Moreover, these conformations have been hypothesized to be buttressed by a number of other proteins, in particular the regulatory and essential light chain and C protein. Well, when I read this background information, I was struck by the fact that myosin, C protein, essential and regulatory light chains are essentially more than 60% of the genes involved in hypertrophic cardiomyopathy. So I was intrigued by that. So I want to show you a schematic about what the biophysicists think is happening during relaxation. So here we have a thick filament with two heads of myosins that are reaching out to the thin filaments to interact with actin and make force. That's contraction, of course. During disordered relaxation, one of the paired heads bends back along the thick filament and its ATPase is inhibited. It can no longer interact with thin filament. It can't hydrolyze ATP. When one has super relaxation, the other head doubles back as well. Now both are inhibited and your consumption of ATP is the lowest. So energy usage by the heart is highest, obviously, during contraction and has two gradated states in relaxation. You can think of this as a really highly tuned motor vehicle that is racing around the motor track and consuming lots of petrol. When you're stopped at the red light, however, the engine's running, you're still consuming energy, but you're not using anywhere near as much as when you're zooming around the racetrack. Or when you're super relaxed, you've turned off the engine, but you left the radio on. And so again, a little energy is still being consumed. All right, why am I telling you all of this? Well, it's all about a spider. As it turns out, these conformational changes have been identified from striated muscles of the tarantula. And a very brilliant biophysicist, Raul Pedron at Caracas University in Venezuela, has been able to generate low-resolution cryo-EM of these different conformations in the tarantula. Well, I contacted Raul and said, that's very interesting, but I want to know what happens in the heart. And so we spent a little time discussing electronically, because my Spanish, as Raquel knows, is very, very bad. And as it turns out, he became very interested when we pointed out that the tarantula striated muscle, and myosin in particular, is 75% identical to myosins in our human hearts. And so what we elected to do was to take his structure and humanize it by substituting in the human amino acids. And I want to show you the kinds of structures that we've obtained, and they're shown here. These are two paired heads of myosin. The free one that can interact with the thin filament is in green, the blocked one is in gold, and it is decorated with the essential and regulatory light chains in blue, shown at the bottom here, because this is the structure of these two myosins in SRX and DRX. With this structure, we could actually identify the particular residues that make contact between a region of myosin and another region of the backbone, a region that interacts with the essential and regulatory light chain, and we could define those particular amino acid residues as being critical for these protein-protein conformational changes. And then we can ask a very simple question. Of all of the myosin mutations out there, are they distributed randomly in myosin, or are they clustered in those interacting protein motifs? And I think you can guess the answer. It's that they are clearly clustered in those interacting motifs. Pathogenic mutations, 78% of them reside in these interacting residues. Likely pathogenic, another 45% of them. If you look at the mutations that are very rare that cause hypertrophic cardiomyopathy in essential and regulatory light chain, they're all in these interacting residues. Okay, maybe we're just lucky. Well, before I tell you about luck, sorry, when we look at what those mutations do, they aren't only in that residue, they change the protein charge in 70% of the chances, so that would suggest that those protein interactions are going to be disrupted. Moreover, there are some interactions that we only see in hypertrophic mutations. We never see them in the general population. All right. So we went in, looked at the general population, all of the exact myosin residues that are found in the general population, and we see that none of those are enriched in these interacting residues. And we looked at patients who have rare myosin mutations and cause dilated cardiomyopathy. None of those also are clustered. Okay, so what this says to me is that hypertrophic mutations are, yes, activating power, but equally so, they are disrupting relaxation. And in fact, these disordered and super relaxed conformations are not symmetric in the two myosin heads. And when you ask where the myosins are most predominant, they are the ones that prevent the formation of super relaxation. And so you, by default, will have more disordered relaxation if you have a hypertrophic mutation. Okay. What does that mean? Well, if you shift the normal proportion of myosin heads during relaxation to be more disordered relaxed than super relaxed, you are going to have more often increased swaying of that one free arm that can hydrolyze ATP and interact with thin filament. That may account for increased interactions and increased force production, aka hypercontractility. Moreover, if you are constantly having this swaying, you are constantly consuming energy, 6-fold more than if you have super relaxation state. By having a disruption of these interacting heads motif, you are therefore going to promote contractility, prevent full relaxation, increase energy consumption, which are really the three major pathophysiologic features of hypertrophic cardiomyopathy. All right, is it true? Well, we can assay ATP consumption by using a non-hydrolyzable ATP called MANT ATP. It's fluorescinated, it binds the pocket of the nucleotide binding domain of myosin, but it can't be hydrolyzed, and so it flows off. If you have disordered heads, the cycling on and off is going to be very rapid. If you have a super relaxed state, it's going to stick and stay there because those ATPs are sterically inhibited. And so we've gone on to measure this in normal mouse hearts from either cardiac tissues or individual myocytes. And we've measured the proportion of myosin heads in super relaxed, shown in red, and disordered relaxed. And you can see that in the mouse, and actually exactly the same percentage are true in the human, about 70% of myosin heads during relaxation are disordered, 30% are super relaxed. All right? What if we look at hypertrophic mice that we've introduced a mutation into? Or, as I'll show you in a minute, if we look in human tissues. And what you see is, as predicted, these shift the proportion of heads away from super relaxed to increasing the proportion in disordered relaxed, up to about 80%. This is a myosin mutation residue 403, and another one mutation 719. I find this remarkable because the 719 missense mutation in myosin is a mutation that has been uniformly associated with diastolic dysfunction, diastolic heart failure. Every patient that I have seen with this mutation has come to cardiac transplantation from diastolic heart failure. And as you can see, as you shift up DRX, you decrease SRX. Okay, so several years ago, John and Jim Spudage and Leslie Leinwan and I decided that maybe we should not treat this condition by trying to modify secondary consequences, but to directly try and intervene with the motor function that is disturbed in hypertrophic cardiomyopathy by looking for small molecules that could alter sarcomere function. And we focused on ATPase because it's an enzymatic reaction that we could assess from small molecule screens. And we identified a molecule, 461. You heard about this yesterday. It's called mavacamten. And we were able to identify this molecule because it inhibits ATP hydrolysis. Shown here in myofibrils, as you increase the amount of 461, you decrease the rate of ATPase and ATP hydrolysis. If you give this to cardiomyocytes, what that translates into is a decrease in contractile force. Fractional shortening drops proportionate to the amount of 461 that you give the cell. So several years ago, we also took our hypertrophic mice with myosin mutations. We've used 3 different mutations, 403, 453, and 719. And we compared the phenotype in mice that were treated from the time they were weaned with 461 and looked for the changes or potential changes in the development of hypertrophic responses. So shown here is a myosin mutation in 403 that is untreated, and you can see that they develop hypertrophy. Mice get very subtle amounts, but very different from wild type, shown in black. And if we gave this animal 461, we abrogate the development of hypertrophy. You get less increase in fibrosis, as shown in this histopathology. You get less induction of the hypertrophic markers, NPPA, BNP, and the like. So we thought this was well and good, and we thought that was a good mechanism for reducing the disease potentially in humans, something that MyoKardia is now trying going forward. But I would suggest to you that what we've just discovered in terms of understanding the process of relaxation asks a different question. If you shift the amount of ATPase pharmacologically, what are you going to do to those conformations in DRX and SRX? In other words, does 461 improve relaxation? So we can do that now, again, in cells by taking them out of animals that have these hypertrophic mutations. And what I'm showing you here, again, is just the profile of the cellular contractility of a wild-type cardiomyocyte, one that carries a hypertrophic mutation on one of the 2 gene copies, and another one with 2 copies, one on each of the 2 genes. And I think you can see the vigorous hypercontractility that you can get from these mutations. They really are hyperdynamic. If we add 461, we profoundly decrease the amount of contractility, but equally importantly, I find my pointer here, suddenly it's gone. We've shifted the proportion of heads from increased SDRX in the heterozygote and the homozygote mutation way back to the amount that's normally present in the wild type. Proportionately, by decreasing the amount in DRX, we increase the amount in SRX. So what that says is that in mouse cardiomyocytes, we can really use a pharmacologic agent and change how relaxation occurs in the heart. What happens in humans? Exactly the same thing. When we take these human tissues from either patients who have had myectomies or have been transplanted, and we look to see what happens in comparison to normal human healthy hearts, there's again an increase in the amount of DRX, a decrease in XRX, but if we add omecamtiv 461, we can shift those proportions back. Now, what I haven't told you is that these last 2 set of slides are in C protein mutations. And these are C protein mutations that are truncating a loss of function. And so what that implies is that C protein has its effect not by anything done globally on the sarcomere, but by directly altering the proportions of heads in SRX and DRX. There's evidence to support this, unfortunately not at a structural level. I'll tell you as an aside that tarantulas don't have C protein, so we can't place it. But from some other analyses that have been done to try and identify the regions on myosin where C protein appears to bind. So what I've tried to tell you is that I think we've learned a whole lot about thinking that hypertrophic cardiomyopathy is a genetic disease to translating that into something that can really make a difference in terms of our understanding of the biophysical properties of sarcomeres, but also in terms of treating our human patients. These mutations are profoundly impactful in terms of causing HCM and DCM, and they are highly different in their functions based on the location of a mutation in a particular gene, the consequences that it will have in augmenting or diminishing sarcomere power, and provide, therefore, incredible tools for really probing basic understanding of sarcomere biology. More importantly, by understanding these, we think that we're developing new tools to be able to treat our patients not by secondary modification of remodeling pathways, but directly at the sarcomere, which is the cause of these pathologies. So I hope you all now know why spiders are good for all of us. It is absolutely essential that you relax in your day and your weekend ahead. I hope you have a wonderful, relaxing time. I want to thank you for being such wonderful hosts and hostesses, and especially to our dear friend and colleague, Raquel Yoti. Thank you very much.
Many thanks, Cricket, for this terrific talk. Let's go to the discussion. I don't know if Salamanca is ready. Are you ready, Pedro? Eduardo?
Yes.
So let's start with Salamanca.
We don't hear you, Salamanca.
No.
It's muted.
And now, in this microphone, can you hear us?
Yeah, it's your microphone, Pedro.
Okay.
I was saying that we are always prepared. Well, thank you very much for these wonderful presentations, and thank you very much for the effort of coming to Spain to give us such wonderful talks. And we also invite you to visit Salamanca. Salamanca is very, very near to Madrid, and it is also a very beautiful city. So
thank you.
It's open for you too.
Wonderful.
Thank you, Raquel, for organizing this wonderful meeting. And thank you, Paco, again, for giving us the opportunity to learn from you. I have 3 questions for all of you in the panel, and also for Cricket and John. My first question is related to the genetic test that we ask in our daily clinical practice. Here in Salamanca, around 50% of people with hypertrophic cardiomyopathy have a negative test. So my question is, what should we do with these people? Should we ask for a test in Boston or Gregorio Marañón, or should we stop studying the genotype of these patients? This is my first question. And my second question is related with atrial fibrillation and ventricular tachycardia, ventricular arrhythmias. Regarding what are your opinions as expert in the panel, are we going to change our clinical practice with the knowledge of the new genotype? I mean, is there going to be an impact of the genotype on the occurrence of atrial fibrillation? For example, we could procedure pulmonary vein ablation prior to the development of AF, or are we going to use this genotype to implant ICDs in the future? So these are my 3 clinical questions. Thank you very much.
So I'll take the first one, and then I'm going to pass it to my friends who haven't done enough work here this morning. So in terms of the mutation-negative cohorts, we think this is a really important group to understand. In my clinical experience, these are often individuals who have a little something else, be that a little hypertension, a little diabetes, a little obesity, and they develop hypertrophy later than do most of the sarcomere mutation patients. In fact, any genotype that we have seen, they present well after the age of 50. While some C protein mutations are late in onset, these can usually be detected using standard imaging in this day and age far younger than that. And so I think that they do have something, and we really do need to understand what it is. Their clinical course is better. Their risk to transmission to the offspring is significantly less. And I want to put that in parentheses because we can't say that until we follow their children until they reach 50, 60, and 70 years of age. And that hasn't yet happened. But from the SHARE registry and other big, large cohorts, they appear to have lower rates of adverse outcomes. What they have is something that I believe will have a genetic substrate, but I think it's going to either be lots of different mutations in lots of different genes, or complex genetics piling up of multiple variants in a few more genes. I don't think there are huge contributors, monogenic causes that have yet to be discovered, given what has been recognized to date from lots and lots of sequencing around the world. It is an opportunity for collaboration. As Raquel knows, we continue to do exomes to try and answer your question. We don't have the answer today. We just don't. Raquel will hopefully provide us with an answer.
Well, I think we need to keep working on
Yeah.
that. We have a lot of work to do, and we don't have the answer yet. So it is worth it to keep working.
Yeah. The clinical, just do the clinical questions, John, because we're a little late. Our clinical, should we do pulmonary veins? Should we put ICDs?
Oh, I don't know. Let's Pedro. Sorry, Pedro. Then what was the question of the pulmonary veins? You even.
Yes, my question is, what's your opinion regarding if there is going to be an impact of the genotype on the occurrence of AF and VT, so we could predict which patients will develop AF and VT, and we could, for example, do as a primary prevention at vein ablation in AF or to implant an ICD. Nowadays, we are not using genotype to decide what patients should undergo ICD. So is this going to change with the exomes knowledge and all the knowledge we are acquiring in genotype?
I think, personally think that there's some association between some mutations or variants and the higher prevalence of atrial fibrillation. But there's not been very major. Am I wrong? There's not major associations. There's some mutations might be, not really.
I agree. The risk is seen with all mutations in all sarcomeres. The risk of AFib is, I think, equivalent. We have not seen a C protein or a myosin being more pro-arrhythmic.
I would like to know the opinion of Angel Arenal. Angel.
Yes.
I know something about the clinical variables related to the sudden cardiac risk, but I have no idea about the genes that are related to the risk of sudden cardiac death. Regarding AFib, I don't know, but probably the degree of hypertrophy has something to do with the risk of developing atrial fibrillation during the follow-up. But as you can see, I'm not an expert in this field, no?
Just to link with the Pedro question, it's true that there are maybe just a few mutations in the heavy chain protein that have been related to a specific high risk of sudden cardiac death. Just 2 or 3 mutations in the converter region. And I would like to know what is your opinion regarding the possibility to implant an ICD in these particular mutations, even if you don't have a proper hypertrophic cardiomyopathy phenotype, or is not too severe.
Yeah. So the question is, can we use genotype alone to manage a patient? And I would say no. We don't use any single clinical parameter. We don't use just the age of a patient, or we don't use just the wall thickness of a patient to make a clinical decision. Do I incorporate genotype in terms of risk stratification? Yes, absolutely. But it is an incorporation, and it's still in the context of looking at the whole patient. We have never, as an aside, we have never seen a genotype positive person with truly no clinical manifestations have a sudden cardiac death. So there are people who have died suddenly, and at autopsy they are found to have unrecognized hypertrophy. Yeah. But if we have images that are contemporaneous with any of these events, we've never seen it be the cause of sudden cardiac death. Have you?
No, the same. The same.
And how about the thin and thick filament and association and value on prognosis? I mean, the Italians, they say that the thin filament are worse, right, in regarding prognosis, particularly because troponin T mutations.
So the troponin T mutations and the troponin I mutations, which are more common in my experience, have been hypothesized to have more arrhythmias associated with them. And while intellectually that makes sense, because calcium dysregulation we know can increase arrhythmic potential. I mean, the long QT syndromes teach us that. But the truth of the matter is in our experience, we have not seen that burden emerge either in the SHARE registry or in our personal experience at the Brigham. And in part, I think that's because the numbers of patients with those are very, very small in comparison to the numbers of patients with the thick filament mutations. And so you could have a high-risk family, and some of it may be that genotype, and some of it may be other parameters, genetic parameters in that family. We just haven't seen it. Have you?
No, I personally, well, we've seen families with troponin T mutations that they behave very badly. Yes, in particular, and we do believe in the converted region as a prognostic marker, particularly the 720, 700, that area, that is particularly bad because they tend to be very early disease and very aggressive, and the children, and they're not gonna do well. Right. And they develop they have an early heart transplantation, arrhythmias and everything.
Those are the ones that have the highest shift in SRX and DRX.
Yeah. I wanted to ask you about the other medical therapies, not just the small molecule, the new mavacamten, but also the molecule, the medications we got in now daily practice at the moment, like the diltiazem that is being associated with a better remodeling at a very high doses in teenagers. That's a Caroline Ho paper, and ranolazine that is being shown that is can prevent the phenotyping carriers in mice. Right. Is that do you believe the ranolazine study and the diltiazem? Do you think we could use it as or could be a potential use in the
so we have not given ranolazine to our mice. So first disclosure, we have not done that experiment. So I read what you read. And I think that it's appropriate from mouse models to extrapolate to humans through a clinical trial. We don't use it as an off-label drug in that population right now because it hasn't had any documentation in any human patients that I'm aware of. So I don't know of a good clinical. Am I correct? Did Gaetian have one just recently? No, I may be mistaken.
Yes.
Yes.
With negative results.
Yeah, with negative results. Yes. No. I've forgotten for a minute. Time zone. Apologize. Yeah, so we have not been using it routinely.
Just one question that yesterday I was discussing with Juanra. Why there are not too many truncating mutation in heavy chains, and they are so well tolerated? Why?
Why are they well?
Why this gene tolerated the?
Go ahead. Yeah.
Well, perhaps.
Is that okay?
Yes. Yes. Of course, please.
Just push the button.
So, I think it's an interesting thought about if we think about a protein complex like the sarcomere. So each component is necessary in the appropriate stoichiometric amounts, and nature does a lot to make sure that each subunit is regulated appropriately. But nevertheless, when you think about the sarcomere, there are literally tens, if not tens of molecules involved. Not every molecule is going to be made at exactly the right amount in every species. Myosin heavy chain, it turns out, in humans and in mice, it's basically fine. If you reduce the amount of myosin heavy chain transcript by half, the mouse is fine. The homozygotes, obviously, they don't do well. If you don't have any myosin heavy chain, it's a hard time. But if you have 50% reduction of myosin heavy chain, they're fine. The same thing in a mouse. If you reduce titin by half, they're fine. If you reduce in a mouse myosin binding protein C by half, they're fine. But there are other genes in the mouse who reduce them by half, and the mouse gets very sick. So I think it's a trick of nature that sometimes some units are just made a little bit in excess, and you reduce it by about a half, and the heart doesn't care. But other ones, you reduce them by about a half, and they care a lot. And if we think about in congenital heart disease, if you reduce the amount of NKX 2.5 by 50%, that's a bad thing. And so clearly the amount of NKX 2.5 really is very tightly regulated. And it just turns out myosin heavy chain is not so tightly regulated. If I could just go back to this question of AF and why, whether there's a gene that is, or genetic predisposition. I think it's really interesting talking about mice one more time. In mice, which are genetically identical, about a third of the mice develop some type of an arrhythmia, even though they're genetically identical. So your job is to explain to me what are the somatic events that occur during the development of a mouse heart or even a human heart, which would predispose to AF or to electrical arrhythmias. So, one obvious answer is fibrosis. And we say, and if you look even at the histology of a mouse, these genetically identical mice, the location of fibrosis is actually quite variable from mouse to mouse. So there are somatic events that, a myocyte dies and then you get replacement fibrosis, and where that occurs, when we say it's random, it means we just don't understand. There probably are very good rules as to why those cells are dying. But but if we extrapolate a little bit to the human, then you could argue that a lot of the AF that one sees is secondary to sort of the same molecular mechanism that cricket recognized, but some cells are dropping out and there's fibrosis in different regions, and obviously physicians have talked for a long time about anitis of arrhythmias being associated with fibrosis and the random events that are associated with that fibrotic event. So we don't need to think about a gene that predisposes, it's rather understanding those somatic events that are predisposing to arrhythmias.
Thank you for sharing, especially your data, your unpublished data regarding this new mechanism. I think it's impressive. And I just was curious, I was wondering if you think that the same mechanism, the decrease in the rate of the super relaxed state can have a role in acquire, not in genetic disease, but in patients with impaired relaxation,
right.
But in other kind of
yes. So
scenario.
Raquel asked the killer question. Can we figure out from a mutation-negative heart if there's a disordered, a change in SRX and DRX? And we're just beginning to do those studies. We don't know. We have done an N of one human tissue, because you can't do a mouse because you don't know what is the complement of genes in there. And in the one heart, we see normal SRX and DRX in a mutation-negative hypertrophic heart. An N of one is an N of one, but it may tell us, certainly this is not the only mechanism for relaxation. Calcium homeostasis is key to relaxation. And it may be there's a whole nother mechanism that in particular targets the thin filament during relaxation. We don't know what they are yet. But one is all we've done, and I think it'll be really important going forward to characterize tissues or cells if we have them, or models if they're developed, of what are these other causes of disordered relaxation, increasing disordered relaxation. As a little aside, we've done some non-sarcomere hypertrophic hearts, the LAMP2 mutation, because we have those tissues, they don't have this imbalance, and actually clinically they don't have diastolic dysfunction. So.
Okay, many thanks. Terrific section. Many thanks, everybody. Unfortunately, we should start to work.
Oh.
So we have to close the session, the meeting. Many thanks again, everybody. Many thanks to all the people from my department, from other departments of the hospital, and many thanks, very special thanks to Juanda and to Roberto. It was great to have you here with us discussing and learning from you. Maria Angeles, many thanks to you. Very special contribution. I thank you very much. And of course, very special thanks to John and to Cricket for the effort and for this incredible amount of learning we received from you. Many thanks, everybody.
Thank
and finally, many thanks, Raquel, for organizing everything. Thank you. Salamanca. Pedro. No, me había olvidado de vosotros, perdonadme. Muchísimas gracias. Ha sido fantástica la conexión y unas intervenciones maravillosas. Muchísimas gracias.
Muchas gracias a vosotros y felicidades por la reunión. Un abrazo a todos.